Ebola disease. From basics to the current 2026 outbreak. What is happening with Ebola right now, and why is the world paying attention again? In this video, we'll break down what Ebola actually is, how it spreads, and what makes the current 2026 outbreak different from previous outbreaks. Ebola is a rare but severe viral disease that affects humans and is often associated with high mortality. Since its first identification in Africa in 1976, Ebola has caused multiple outbreaks, with historical case fatality rates ranging from approximately 25% to 90%, and averaging around 50%, depending on the viral species, healthcare availability, and outbreak conditions. Ebola is not caused by a single virus. Several related viruses belong to the genus Orthoebolavirus, but 3 species are responsible for the major human outbreaks: Ebola virus, Sudan virus, and Bundibugyo virus. Among these species, only classical Ebola virus disease caused by Ebola virus currently has approved vaccines and WHO-recommended virus-specific therapies. Approved vaccines and treatments are not yet available for Sudan virus disease or Bundibugyo virus disease. Ebola is considered a zoonotic disease, meaning it originates in animals before spreading to humans. Fruit bats are believed to be the natural reservoir. Human infection is thought to occur after close contact with infected wildlife, including blood, organs, secretions, or contact with sick or dead animals. Once introduced into humans, transmission occurs through direct contact with infected blood, vomit, feces, secretions, other body fluids, or contaminated surfaces and objects. Ebola is not transmitted through the air like COVID-19 or influenza. Importantly, infected individuals are generally not contagious before symptoms begin, but remain infectious while the virus persists in blood and body fluids. The incubation period ranges from 2 to 21 days. Early symptoms are often nonspecific and may resemble many common infectious diseases, making diagnosis difficult during the initial stages. Typical early manifestations include sudden fever, profound fatigue, muscle pain, headache, and sore throat. As the disease progresses, patients may develop vomiting, diarrhea, abdominal pain, rash, kidney dysfunction, and liver injury. Although Ebola is commonly associated with bleeding, hemorrhagic manifestations are not universal and usually do not appear early in the disease course. Severe cases may progress to internal or external bleeding, neurological involvement, confusion, irritability, and altered mental status. Because early symptoms overlap with conditions such as malaria, typhoid fever, meningitis, and other febrile illnesses, laboratory confirmation is essential. Diagnostic methods include reverse transcription polymerase chain reaction, also known as RT-PCR, antigen detection tests, and antibody-based assays such as ELISA. Sample handling requires strict biosafety measures due to the extreme biological risk associated with potentially infectious material. Treatment depends on the viral species involved. Across all forms of Ebola disease, early supportive care remains the most important intervention for improving survival. This includes aggressive rehydration, intensive supportive management, nutritional support, symptom control, and treatment of associated infections. For classical Ebola virus disease, approved monoclonal antibody therapies are available. Vaccination is also available only for classical Ebola virus disease, with approved vaccines including Ervebo and the Zabdano-Mvabea regimen. Vaccines and specific therapeutics for Sudan virus and Bundibugyo virus remain under development. Successful outbreak control extends beyond vaccines and medical treatment. Effective containment relies on rapid identification of suspected cases, patient isolation, laboratory confirmation, contact tracing for 21 days, use of personal protective equipment, infection prevention protocols in healthcare settings, safe and dignified burial practices, and sustained community engagement and public education. Follow-up after recovery is also important because Ebola viruses may persist temporarily in immune-protected sites such as the eyes, testes, and central nervous system. The current Ebola event attracting international attention began in May 2026 in Ituri Province, Democratic Republic of the Congo. On May 5, 2026, the World Health Organization received an alert regarding an outbreak of an unknown illness associated with unusually high mortality, including deaths among healthcare workers. Laboratory investigation later confirmed the outbreak on May 15th as Ebola disease caused by Bundibugyo virus, a less common Ebola species. This distinction is medically important because Bundibugyo virus differs from classical Ebola virus. Unlike classical Ebola virus disease, there is currently no licensed vaccine and no approved virus-specific treatment for Bundibugyo virus disease. Management, therefore, depends almost entirely on rapid diagnosis, patient isolation, supportive care, rehydration, and optimized clinical management. Historically, Bundibugyo virus outbreaks have shown case fatality rates between approximately 30% and 50%. The current outbreak has raised concern not only because of disease severity, but also because of delayed recognition. Investigators estimate that nearly 4 weeks passed between symptom onset in early cases and laboratory confirmation, creating opportunities for community transmission and reducing early containment capacity. The outbreak appears to have originated in a highly mobile mining region in Ituri, an area characterized by intense population movement, cross-border travel, insecurity, and limited healthcare access. These conditions complicate surveillance, laboratory transport, rapid response deployment, and contact tracing. Epidemiological observations have also shown that more than 60% of suspected cases occurred in women between 20 and 39 years of age, likely reflecting household exposure and caregiving roles. At present, confirmed outbreak activity has been reported only in the Democratic Republic of the Congo and Uganda. Uganda confirmed imported Bundibugyo virus disease cases originating from Congo, including cases identified in Kampala and additional infections among healthcare workers receiving treatment and triggering expanded contact investigations. According to the latest WHO reporting, the outbreak has exceeded 900 suspected cases, more than 100 laboratory-confirmed cases, and more than 200 reported deaths under ongoing epidemiological investigation. These figures continue to evolve as surveillance and laboratory confirmation expand. Due to cross-border spread and the need for coordinated international action, the World Health Organization declared the outbreak a public health emergency of international concern. Current response efforts focus on rapid response teams, laboratory expansion, treatment centers, infection prevention and control, contact tracing, border preparedness, healthcare worker protection, and community engagement. Although this outbreak is being monitored internationally, control efforts remain centered on classical public health principles: early detection, isolation, supportive care, contact tracing, healthcare protection, safe burials, and coordinated international response rather than reliance on vaccines alone, Ebola remains one of the world's most serious infectious diseases. But early detection, supportive care, and public health response continue to save lives. If this video helped you understand the current outbreak, subscribe to Easy Medicine for more high-yield medical content made simple.